Dear friends, dear colleagues, it's my pleasure. It's my pleasure to welcome all of you on our discussion club on acute heart failure. No doubt, acute heart failure is an emergency condition that play critical role for many patients with ischemic heart disease, heart failure, and we need to have accurate diagnosis and timely treatment with this very much important condition. I think the goal of our club to share experience of knowledge of the diagnosis and treatment of acute heart failure. Very important to discuss current issues in this field and the reign awareness of acute heart failure among professionals. I hope that our club will become as a platform for fruitful cooperation between cardiologists, between other professionals, to become an important source of information of acute heart failure and stimulus for development of new methods of diagnosis and treatment of acute heart failure. I am sure that our meeting will be interesting and useful for all participants. I wish you all a productive work.
For this kind introduction.
Thank you very much.
Thank you very much, Evgeny Vladimirovich. Now we can start our meeting. Before to start our meeting, Professor Ovidiu, we are using two working languages. For some of part, it will be English language. For another part, it will be Russian language. Of course, you can use chat to discuss some issues. Now, I am kindly ask all participants to mute their microphones. And if they want to ask questions, please use chat. First issue. And second issue, when we start discussion, please raise your hand using the Zoom link. Дорогие друзья, я вас всех приветствую из
Dear friends, I'm welcoming you. There are representatives from post-Soviet space, from CIS, colleagues from friendly countries of CIS, and I have got a request. Please do use the chat to ask questions. These questions will be then transferred to Professor Chancellor. And when we discuss everything, it will be possible to raise your hand and to come up with remarks or questions on this very important topic, as Professor Šляchto said, that is the management of patients with acute heart failure.
Introduce Professor Ovidiu Chioncel, our big friend, world expert in the field related with heart failure and acute heart failure as well. Professor Chioncel, the screen is yours now, please.
First of all, thank you so much, Yuri, and thank you so much for this initiative. And I would like to start saying big congratulations for gathering so many people with interest in heart failure, and particularly in acute heart failure. And without any further ado, I will share my screen, and I hope that you see my presentation.
Yes, everything is fine.
Just to So, Yuri, everything is okay?
Yes, of course, everything is okay. We see your presentation and we can hear you. Please.
Thank you so much. So, first of all, acute heart failure is a very severe disease. And we are so familiar saying about in-hospital mortality, but actually in hospital mortality, it's between 4 and 6%. We are also very familiar with European long-term registries discussing about 1 year mortality. And 1 year mortality, it's between 25 to 27%. But this is a most recent statistic saying that survival at 10 years after heart failure hospitalization, it's around 17%. This is truly a severe disease, and this justifies any intervention to treat and cure heart failure. And this is a new conceptual framework for acute heart failure. Patients with acute heart failure may present with rapid or gradual onset. And you see some patients may have de novo heart failure without any history of heart failure, but there are others. The rest of the patients, actually most of the patients, 70% of the patients have a history of heart failure. They may present not only in emergency department, they may present as outpatients. They may present in emergency department. And this is the new concept of worsening chronic heart failure. And venue of care is not a biological threshold. And patients may have a similar risk to die irrespective if these patients are receiving furosemide in outpatient settings or in emergency department or during hospitalization for worsening heart failure. Other important conceptual change in acute heart failure management, it's dividing in phases. One, it's immediate phases. The second, it's intermediate phases. And the last, it's pre-discharge phases. And you see 2021 guidelines of heart failure, it's providing specific objective of management for each of these phases. This is important also for disposition therapy, because we can discuss about treatment, about IV inotrope, IV diuretics, about mechanical circulatory support, but equally important, it's disposition decision where to admit patients with signs and symptoms with heart failure. And the most severe patients are admitted directly in ICU, while vast majority of patients are admitted in the ward. And this is very, very important. And there are several documents suggesting how to admit and where to admit patients with signs and symptoms of heart failure. As stipulated in the guidelines and very well positioned statements, first medical contact is critically important. And the first 60 minutes, first hour after presentation, it's important because we need to collect vitals. What does it mean, vitals? Systolic blood pressure, heart rate, oxygen saturation, and temperature. And also very important is to identify life-threatening triggers. These conditions have specific management pathways, and they should be treated before any congestion hypoperfusion algorithm. These are actually championed. This is an algorithm modified a little bit from previous CHAMP, adding I from infection and T from tamponade. And this is working very well because, you know, one important commandment of acute heart failure, that diagnosis and management of patients with acute heart failure should go in parallel. And after exclusion of CHAMP-IT, we may classify our patients based on clinical profile. These clinical profiles are decompensated heart failure, acute pulmonary edema, acute right heart failure, and cardiogenic shock. And this classification, although with some overlappings, between clinical profile because some patients may be difficult to diagnose between decompensated heart failure or acute pulmonary edema. But even so, this type of classification, it's giving different line of management for each clinical profile for decompensated acute pulmonary edema, acute right heart failure, and cardiogenic shock. Unfortunately, you know very well, and we know very well, we are assisting at 2 decades of negative randomized clinical trials in acute heart failure. What we learn from these trials, that 1/3 to 30%, 35% of acute heart failure patients are discharged with residual clinical congestion, and this congestion at discharge is associated to a poor prognosis in terms of 1-year mortality and readmissions. That's why when we are dividing patients in this clinical profile, we should fix as minimum residual congestion at discharge. For patients admitted with decompensated heart failure, treatment of congestion based and it's actually suggested by HFA position statement algorithm, doubling IV diuretic dose, doubling IV diuretic dose, and then adding combination therapy like thiazides, indapamide, or mineral receptor antagonist. And this decision tree, it's following those clinical trial, saying that initial IV furosemide dose should be 2.5 times higher than previous oral diuretic dose. It's also the first time when we define what does it mean satisfactory diuretic response in terms of urinary sodium content, more than 70 milliequivalents per liter at 2 hours, and or urinary output more than 100 milliliter per hour during the first 6 hours. Very interesting because in 2021, this was only a suggestion. Only in 2023, we had a confirmation from PUSH acute heart failure trial, saying that natriuresis guided diuretic therapy in acute heart failure is associated to better decongestion, in spite no any effect on hard endpoints like mortality and readmission. Also, because I mentioned those trials, which compare low versus high and continuous versus intermittent administration of diuretics, higher diuretic dose with continuous administration were associated to better decongestion, but again and again, without any effect on death or readmission for heart failure. We learn a lot about this hysteresis curve, showing threshold effect and ceiling effect, and how to add combination therapy to improve diuretic response in patients with heart failure. And remember, this diuretic response, this hysteresis curve, it's displayed to the right in patients with advanced heart failure or renal heart failure. For thiazides, you know very well they are working in distal nephron, where less than 5% of sodium is filtered. But in patients chronically treated with diuretics, there is a compensatory reabsorption in distal nephron, and this is a rationale why to use, in addition, thiazides over IV furosemides. Actually, we have a clinical trial, and this is chlorotic trial, describing sequential nephron blockade in patients admitted with decompensated heart failure, saying better decongestion when adding thiazides over IV furosemides, but again and again, look at all-cause mortality, readmission, and impaired renal function. All got worse in patients with thiazides. Other interesting concept is tubuloglomerular feedback, So tubular glomerular feedback, it's increasing sodium reabsorption in proximal nephrons. And this was an excellent rationale for ADVOR trial, showing that adding IV acetazolamide in patients with decompensated heart failure over IV furosemide, it's improving decongestion. But again, look, numerical more deaths in patients with decompensated heart failure and treated with acetazolamide. And at the end of the day, only one intervention, and this is SGLT2 inhibitor empagliflozin, which was associated to improving decongestion and improving mortality and readmission. There is only one intervention which has no disconnection between decongestion and 90-day outcomes. And this is important signal for medical community. How to do in specific clinical settings, let's say for patients with hyponatremia, we should distinguish between dilution and depletion hyponatremia. When it's dilution, stop thiazides and use acetazolamides or SGLT2 inhibitors. When it's depletion hyponatremia, add osmolar hypertonic saline solution. There are a lot of debates about using of dopamine as diuretic enhancer, but I should remember you, we have 2 clinical trials, DEAD-HF and ROSE trial, showing no any benefit after addition of dopamine to standard IV therapy. So on basis of current data, dopamine has no any role in non-hypotensive patients with acute heart failure, just to increase diuresis. For patients with high intra-abdominal pressure, defined as more than 20 millimeter mercury, a reduction in intra-abdominal pressure can be achieved through a combination of diuretics, vasodilators, or even anotropes. And for patients with abundant ascites, we need paracentesis. In very few patients, ultrafiltration may be considered, but remember, we have 3 clinical trials with ultrafiltration. These trials, at the end of the day, were negative because all clinical trials were associated to deterioration of renal function and no improvement in mortality or readmission. We may consider, and this is a modern strategy, we should see what future will provide us in terms of device therapy, pusher and pullers, who decrease venous pressure, renal venous pressure, or increase perfusion at the kidney to improve diuresis. For patients with acute pulmonary edema, we have 3 commandments: correction hypoxemia, relief of pulmonary congestion, and treat hypoperfusion, and hypoperfusion coexist. For correction hypoxemia, the guidelines are very clear, and just mentioning oxygen therapy, non-invasive ventilation, and mechanical ventilation, mentioning once again what our colleagues anesthesiologists is providing for intubation class 1C in case of respiratory failure in spite of oxygen and non-invasive mechanical ventilation. And practically, this is a very nice scheme provided by our colleague Joseph Masip, showing how to deal patients with acute heart failure and respiratory failure, and how to use mechanical ventilation in terms of non-invasive or intubation. It's very nice, and it's conceptually appealing to phenotype congestions in terms of redistribution or overall fluid overload. And we may have a lot of clinical signs, and just to add echocardiographical signs saying that we have redistribution, pulmonary congestion, we may start with vasodilators, and when we have systemic congestion, we may start with IV diuretics. And typical for pulmonary edema, it's a redistribution pathophysiology, but look at clinical trials, we have two clinical trials, Galactic and Elizabeth, showing no any benefit from early sustained IV vasodilation in patients admitted to with pulmonary edema. Again, we have class 3 now for morphine in acute pulmonary edema, and I remember you when I started medicine 25 years ago, we were using morphine for patients with pulmonary edema. We have 3 propensity matching score analyses showing excess of adverse reactions and maybe significant harm. And the last clinical trial, MIMO trials, comparing morphine with midazolam, was also negative, showing increasing cardiac adverse effect in patients treated with morphine. For patients with acute heart failure, the main clue is to identify the main trigger and relationship between pulmonary vascular resistance, baseline right ventricular dysfunction, and severity of tricuspid regurgitation, is to create a pattern. Which is the main trigger? Primary right ventricular dysfunction. It's primary tricuspid regurgitation with secondary right ventricular dysfunction. It's typical scenario with pulmonary hypertension, with increasing pulmonary vascular resistance, or it's additional scenario with tamponade or pericardial constraint. For patients with cardiogenic shock, you know very well, it's a true immediate life-threatening condition, and you see about 1/2 of the deaths are occurring in the first 24 hours of admission. And this is critically important when you are dealing with these patients with cardiogenic shock. Let's say this is the reason why the guidelines divides phases of therapy for cardiogenic shock, and firstly is for sure stabilization, and secondly and most important is to identify and treat underlying cause of cardiogenic shock, because without identifying underlying cause of cardiogenic shock, the outcome it's usually fatal. We are in the world of devices, of modern treatment, but remember, our patients need not only inotropic vasopressor or mechanical circulatory support, our patients need mechanical ventilation, our patients with cardiogenic shock need renal replacement therapy, need heparin, need antiarrhythmics, and need parenteral nutrition, and need administration of potassium, magnesium, and need antidelirium medication. So a lot of medication. So successful management for patients with cardiogenic shock is not only inotropic mechanical circulatory support, is to use all this medication to prevent organ dysfunction or to treat organ dysfunction in patients with cardiogenic shock. And this is becoming critically relevant in the last years. When you remember, we have 2 negative clinical trials. ACLS shock trial was negative. No any significant difference in terms of 30 months mortality for VA ECMO patients with post-MI cardiogenic shock. And this is Czech trial, ECMO cardiogenic shock, showing no any difference in early versus late ECMO in patients with cardiogenic shock. And this is the reason why we should refocus our attention on preventing multi-organ dysfunction in patients with cardiogenic shock and appropriately selecting patients who truly require mechanical circulatory support. One important phase in patients with acute heart failure, regardless, irrespective of clinical phenotype, it's pre-discharge phase, when we should assess residual congestion, but also to initiate, up-titrate medical therapy. And actually, we are assisting to a changing a paradigm from heroical perspective in emergency department in a more wise approach in pre-discharge phase. And this hypothesis was tested in a clinical trial strong HF. And strong HF tested hypothesis of rapid uptitration of guideline-directed medical therapy, but not only rapid uptitration, coupled with intense follow-up. The results of these clinical trials show significant increase in oral guideline-directed medical therapy at day 90 as 3 months and 3 months, and this uptake of medical therapy was associated to significant benefit in terms of all-cause mortality and heart failure readmission, with no significant differences in serious adverse event. And very interesting signal, these results in strong was observed irrespective of ejection fraction. So similar results in patients with reduced and preserved ejection fraction. At the end of the day, I would like to mention this. We have several 20 years trial with enhanced decongestion therapy. They're improving congestion, but none of these trials are associated to improving outcome, also for vasodilation. Only opportunity to improve outcome, its initiation of guideline-directed medical therapy, and we have direct proof from Pioneer, from Impulse with empagliflozin, Soloist with sotagliflozin, and more recently in strong rapid uptitration. These are strategies associated to improving prognosis. And I want to mention this was published last week, enhanced decongestion versus guideline-directed medical uptitration, rapid uptitration, and you see enhanced decongestion is associated to increase neurohormonal activation and maybe adverse effect in terms of decreasing blood pressure, decreasing potassium and glomerular filtration rate, totally distinct to guideline-directed medical therapy uptitration, and this translates in better outcomes in terms of mortality, readmission, and quality of life. This will be published very soon, and this is an interesting signal. When rapidly uptitrate medical therapy, although may be difficult in the first week after discharge, decongestion is better than usual care in this patient, and this is an important signal. So be wise, initiate an uptitrate medical therapy versus enhanced decongestion without any reason. And I will like to stop here. Remember you, this is a best meta-analysis. Actually, it's a meta-regression, including 15 million hospitalization due to acute heart failure in the last 40 years, showing a trend in improving long and short-term mortality. And this trend of improving mortality was due to additional beta blocker and renin-angiotensin system inhibitors and no to treatment of congestion. And again, be wise, use medical therapy at discharge, classify your patients, and give any chance to your colleagues to identify etiology of acute heart failure. Thank you so much. I'm open for your questions.
Excellent. Many thanks, Professor Ovidiu Chioncel, for this fantastic review of the current management of patients with acute heart failure. We really enjoyed your presentation, and of course, this presentation is generating many questions to you. I'll check the chat about that, and then we will start our discussion. One question is related with the using of mechanical circulatory support for patients with acute heart failure. Could you please share with us the current situation about the using of mechanical circulatory support in such category of patients?
Thank you so much, Yuri, for asking me this question. As you remember, in 2021 guidelines, the level of recommendation for mechanical circulatory support is 2B. 2B means we don't have clinical trials. We even have class 3 recommendation for intra-aortic balloon pump, but remember, as routinely used post-acute myocardial infarction. There is a trend of increasing other type of devices like Impella and VA ECMO. But what we have till now, we do not have any positive clinical trials to justify upgrading indication level of recommendation for patients with mechanical circulatory support. As I mentioned in my presentation, we have two recent clinical trials, ACLS shock trial and the ECMO cardiogenic shock trial, showing no any benefit from VA ECMO in patients with cardiogenic shock. Again, we should be wise because implantation of mechanical circulatory support in patients with severe and irreversibly multi-organ dysfunction is not bringing any benefit. Again, implanting these devices in patients without, just as prevention, without organ dysfunction is not bringing any benefit. I think that we should better decide how to select right patients who may benefit from these devices. Actually, also in my institution, we are reference center for VA ECMO. We are using a lot of VA ECMO. But in patients with post-MI cardiogenic shock, VA ECMO is a disaster because it's increasing afterload. And very often we are using VA ECMO in conjunction with intra-aortic balloon pump or in very, very rare situation with Impella. Impella is very expensive, and we have two analyses, 2021, 2022, coming from United States, the second one from Europe, comparing, yes, not in randomized clinical trial settings, but post hoc retrospective analysis, but analyzed in propensity matching score, showing excess of risk, bleeding, and vascular complication of Impella when compared with intra-aortic balloon pump. I grown up with intra-aortic balloon pump, and I like very much. And I still seeing a lot of physicians don't paying attention how to synchronize, how to use intra-aortic balloon pump. And I think that, I also think that in a special situation. What?
Excuse me, yes.
Вопрос можно будет задать позже чуть-чуть. Я дам слово. Пожалуйста, please.
Yes, you continue. Questions will be later. Continue, Professor. Questions will be later. Okay?
No. I have just to highlight that we need to relearn. Also, young physician, mechanics of intra-aortic balloon pump, and also not only in my country, but in many European countries, intra-aortic balloon pump is still used as first mechanical circulatory support.
Thank you. Academic Kurbanov, Uzbekistan.
Academician Kurbanov from Uzbekistan, president of Uzbek Association of Cardiologists, has a question. Your question, please. Well,
Стенозом и острой фасовой картой с кардиальным шоком. Критический стеноз артерии. Плюс острый инфаркт миокарда с кардиальным шоком.
critical stenosis and acute myocardial infarction and cardiogenic shock. Imagine such a situation. So, what should be the device? Thank you very much.
So in patients with acute myocardial infarction, critical coronary stenosis, and cardiogenic shock. This was your question, yes?
That's true.
Yes. And what type of device?
Not only device, in general, how to manage such complicated patient.
Very good questions. There is an American concept, which is called, and it's coming from Detroit initiative, NCS initiative, saying early unloading before reperfusion. But to be honest with you, we do not have any proof, any evidence coming from clinical trials to use this initiative. So I'm still thinking, and this is also guidelines recommendation, to start with revascularization, and then if hypoperfusion persists, to use mechanical circulatory support. For sure, if you have Impella, probably it's better to use Impella. But I also think that first device in patients with truly cardiogenic shock may remain intra-aortic balloon pump, and in case of worsening hypoperfusion, we may add VA ECMO. Starting at the beginning with VA ECMO, as I said, it's a disaster. So we need a device which are decreasing afterload, and we have only two. One, it's Impella, and the second, it's intra-aortic balloon pump. Remember, Impella, it's 40,000, 60,000 euro. Intra-aortic balloon pump, it's 800 euro.
Thank you very much. The next question will be from the Professor Villivaldi. Svetlana Vladimirovna.
Professor Chioncel, thank you very much for your excellent review and presentation. It's well known that subclinical congestion is prognostic negative factor. For your opinion, what's practical algorithm we can use, or maybe you use in your clinic? Is it Vexus protocol, short ultrasound protocol, biomarkers? What algorithm? Thank you.
Thank you so much for the questions. First of all, we should use clinical congestion score. You remember the first clinical congestion score was validated by Mihai Gheorghede in numerous clinical trials, including dyspnea with orthopnea, pedal edema, rails, and visual analog scale. There are many others in PROTECT trial, in ADVOR trial, a lot of clinical congestion score. What it's important is to see variation in this score, admission compared to discharge. So clinically, it's important. But even so, in some patients, they are flying under the radar. They have no clinical signs of congestion, but have high NT-proBNP value, have high value of E to E prime, have high osmolality or low hematocrit values. Some of these patients are still without clinical congestion, but with B line of focus echocardiography. So my idea is to consider all of these clinical signs, B lines at the echo, hematocrit, changing hematocrit, natriuretic peptides, but we do not have a hierarchy which is better. clinical science or NT-proBNP or E2E prime. What we are very sure, a decrease of more than 30% of NT-proBNP at discharge compared with admission has a very good prognosis. But we have no any data saying that decreasing in NT-proBNP is better than resolution in clinical science. So at the end of the day, my idea is to consider all of this and to compare admission versus discharge.
Thank you.
Many thanks. We have very good question from Dr. Fedotov, St. Petersburg. The question related with myocardial revascularization. Dr. Fedotov is thanking you for the fantastic report and asking you about the benefit and risk, what is the ratio of benefit to risk of myocardial revascularization in patients with significant reduction of ejection fraction and many zones of akinesia by echo. But in patients with hemodynamically significant stenosis of arteries, do we need to clarify the viability of myocardium in such patients?
So, Yuri, excellent questions. You know very well, all of you, we have two clinical trials, ischemia trial and revised BRICS trial showing no any benefit from interventional procedures as compared with medical therapy in patients with heart failure without clinical signs of angina. But this is totally distinct in patients with acute heart failure. Patients with hemodynamic instability should undergo coronary angiography and as much as possible revascularize these patients. Of course, it's quite impossible to have assessment or reproducibility of ischemia in acute settings. But patients with very low ejection fraction, diabetic patients, are strongly benefiting from revascularization. There is only one problem here. First commandment in patients with acute heart failure saves the life. And I think that we should go forward to revascularize these patients. Other problem is quantity of reverse remodeling. And as you know, we have very old study, but are still acceptable in terms of evidence, saying that end systolic volume, more than 130 milliliters, it's preventing favorable reverse remodeling. But finally, in patients with acute heart failure, with any kind of hemodynamic instability, revascularization may have a role.
Many thanks. And the next question will be from Vice President of the Russian Society of Cardiology, Professor Duplikov. Dmitry Viktorovich.
Thank you. Thank you. First of all, thank you, Professor Chioncel, for such a state-of-the-art presentation. And my question is slightly strange. I came across about interesting papers published mainly from Germany when authors use, let's call it emergency resynchronization therapy in patients with acute heart failure, but with left bundle branch block as well, and without STEMI. So they got very interesting results, promising results. And what do you think about such approach?
Very good question. So I will make a short history. 25 years ago, the first resynchronization was in the patients with acute heart failure. Serge Cazot implanted a resynchronization lead in coronary sinus in a patients with diuretic resistance. And after resynchronization, these patients had 20 kilos less and significantly improved. Now, in terms of guidelines, in terms of clinical trials, we need at least 3 months of optimal medical therapy. But this is clinical trials. Real clinical settings is different. And I remember I have also in my institution patients with acute pulmonary edema, ejection fraction of 30%, 100 beats per minute, and left bundle branch block with severe mitral regurgitation. Tell me, what kind of therapy you can give to these patients? Nothing. Giving IV inotropes, you'll increase mitral regurgitation and you will kill the patients. Giving IV furosemide, you will decrease systolic blood pressure. And for this kind of patient, we applied emergency, let's say, cardiac resynchronization therapy.
Thank you. We have Angela Solovyova. The question is related to using of hypertonic saline in acute decompensated heart failure, and especially in patients with diuretic resistant cases. So could you share your experience, your thoughts about the using of this option?
Yeah, Yuri, it's an excellent question. So actually we have 2 pieces of evidence. One, it's a meta-analysis, 2022, showing the benefit in terms of decongestion, improving diuretic response, and decreasing the number of hospitalization in patients with hypertonic saline solution. But first of all, we should distinguish between dilutional and depletional hyponatremia, because depletional hyponatremia is not so common. We should be 100% sure that it's depletional hyponatremia when using hypertonic saline solution. We are using in our institution this type of patients. But remember, sometimes in terms of diuresis, it's a matter of sodium-potassium pump. And these pumps becomes exhausted when exposing to low sodium concentration. And this is the reason we try to increase the sodium at the level of proximal tube to make ATP pump works better. But again, this treatment should be given with additional IV furosemide dose. We are using double dose, so not 0.45, but 0.9 sodium saline solution, 500 milliliters or 1,000 milliliters in addition to IV furosemide. What is important for these patients is to measure urinary sodium.
Thank you very much. We have one question from Professor Sitnikova. Professor Sitnikova is asking you about the control of congestion in patients with heart failure. What will be your recommendation about the using lung ultrasound, RETS technology, or control of inferior vena cava? Which method you prefer to use in your hospital?
Yuri, as I said, all of this. But remember, inferior vena cava, it's working very well in clinical practice. And it's also working very well irrespective of clinical settings. Inferior vena cava variation with respiratory variation is working in ICCU, in the ward, in outpatient settings. While B lines, a number of B lines, and look at the manuscripts, were totally different when considering the number of B lines of discharge associated to prognosis. When you consider comparison between admission and discharge, this is okay because you can measure the quantity of the magnitude of decongestion, but to have a specific number of B lines associated to a good prognosis, it's quite difficult because of differences in authors, investigators who consider this. While for inferior vena cava, respiratory variation and dimension less than 21 millimeters is working very well. So I'm using inferior vena cava. I'm also using B line, but should remember specificity of B lines because also patients with acute respiratory distress syndrome may have B lines, patients with pneumonia, because you need some kind of experience, expertise to distinguish between B lines and the line associated with pneumonia. And you remember when we have COVID, we have a lot of patients with B line and only pleural continuity or pleural discontinuity was helpful in making difference between COVID and acute heart failure. And I'm using also anti-proBNP. So clinical signs plus inferior vena cava plus anti-proBNP, it's working very well. When you are using, because not only experts, we should give clear signal for people working in community hospitals. And people in community hospitals have no B lines, have no anti-proBNP. For this kind of people working in community hospital, decreasing hematocrit, it's associated to a poor prognosis and make sense to assess residual congestion, while increasing hematocrit, it's associated to decongestion. So consider all of this.
Okay, one question from Dr. Fedotov. Dr. Fedotov is asking you about hyponatremia during the using of SGLT2 inhibitors. Do you meet such patients in your clinical practice?
Are very rare, Yuri, are very rare. And actually, I'm using SGLT2 inhibitor to prevent or treat hyponatremia because it's producing osmolar diuresis. It's very rare.
Okay, one question related with the place of levosimendan, comparing with inotropes and vasopressors in the management of patients with how you establish the place of levosimendan?
So levosimendan is excellent drug, and I liked very much. But practically in the last days, levosimendan moves, at least in my institution, in operative ICCU. So we are giving levosimendan like intra-aortic balloon pump in patients with high-risk surgery, cabbage surgery with mitral regurgitation, 24 hours between surgery. So in patients with acute decompensated heart failure, because of hypotension, we are not giving bolus of IV levosimendan, we are giving continuous perfusion. But believe me, I had more than 200 or 300 administration of levosimendan in my life. In 70 to 80%, we should add norepinephrine. It's so unpredictable, decreasing at systolic blood pressure, and I'm a little bit concerned about the right place of levosimendan in cardiology settings. We may use levosimendan in right ventricular cardiogenic shock, but also with norepinephrine. It's working very well. working very well. But otherwise, it's expensive, it's producing vasodilation. And although I don't like at all, we should start with dobutamine.
Thank you. President of the Armenian Association of Cardiology, thanking you for your great presentation. And the question is, when you recommend starting beta blockers after acute heart failure event, as soon as possible in the hospital or after discharge?
No, Yuri, for sure in the hospital. Do what you think it's possible to minimize congestion. And if your patient, it's reasonably decongested, heart rate, it's more than 60 per minute, systolic blood pressure, it's more 100, initiate beta blocker. We may use hospitalization also as an opportunity to initiate an up-titrate oral therapy. Because we like very much, we are cardiologists, we are very, very nice, very clever, and like to see our patients like a reservoir to implant devices. We like very much to implant TAVI, MitraClip, as in my institution, and when we have patients to up-titrate medical therapy, just writing in medical discharge. General practitioner should do up-titration, but it's our duty to initiate as soon as possible beta blockers during hospitalization.
Okay, we have a short period of time. Maybe some colleagues from our audience want to ask something. Коллеги, у кого есть желание высказать свою точку зрения?
Colleagues, are there any questions from the floor? Let me say a few words. Of course, Yuri Nikitovich, president of the Society of Specialists on Heart Failure of Russian Federation.
Well, as I understand, I had to speak English.
Yeah.
Thank you so much for excellent presentation. It's very important for us to get a knowledge about your experience in the acute congestive heart failure. But you know, it's now it's not more than my presentation or my talk. That my question. What's your opinion? What's the best way to prevent acute case in heart failure and to prevent the readmission to the hospital in our everyday practice? What can you recommend for our doctors, for our physicians who follow these patients each day? How to prevent the acute accident? That's the question.
Yeah, thank you. But it's a very difficult question because when we are reading the guidelines, one of the phrases related to acute heart failure, clinical severity in acute heart failure, it's a complex interplay between cardiovascular substrate, triggers, and associating non-cardiac comorbidities. And we should take care of everything. And first of all, take care of non-cardiac comorbidities, because when patient has many associated non-cardiac comorbidities, his or her propensity to become unstable, it's increasing. Treat diabetes, treat renal dysfunction, treat iron deficiency, and probability to have decompensation, it's decreasing. Other important issue, and we have so many tools. Half of hospitalization in patients with acute heart failure are of non-cardiac origin, are due to worsening COPD, are due to infections, and so on. we do not have too many instruments to prevent this kind of hospitalization, but just initiation of up-titration medical therapy is preventing heart failure-related hospitalization. For the rest of them, the best issue is to treat non-cardiac comorbidities. And very important, very, very important, is the role of multidisciplinary program. It's sounding like an stupid language because it's so expensive. It's so expensive to have a multidisciplinary program. Let's imagine, my hospital is very good. We are doing left ventricular assist device, TAVI, mitral clip, but we have no money. We have no money to pay for follow-up of these patients and to refer these. We have no money, no time to refer these patients to diabetologists, nephrologists, neurologists, and so on. So I like very much what the guidelines are saying, multidisciplinary program, but this is on wishful thinking. I don't know, except northern country like Sweden, Finland, which are very small country, to realize this. So it's difficult to prevent hospitalization, at least non-heart failure-related hospitalization.
Thank you so much. I have the same position with you, and of course these comorbidities, they are very flexible because as we get to know from the priority study which we had in my country last year, we include 20,000 patients with the congestive heart failure, and if we speak about the comorbidities, on the third place came the chronic kidney disease. They overcome diabetes mellitus, type 2 atrial fibrillation. Of course, on the first place is arterial hypertension. On the second place is ischemic heart disease and acute myocardial infarction. But on the third place, it's chronic kidney disease. And we had to pay attention to that, especially when we use such medications which you excellent describe in your lecture. So the comorbidities, I think the cornerstone to prevent the readmission to the hospital, because such a pity we have no magic pill to prevent all these devices, all these events. I'm sorry. Even if of course we dream in the sacubitril valsartan, then we dream to the gliflozins. Now we dream to the other medications. Hope for that, but of course I totally agree with you that it's a very difficult teamwork. Thank you so much for this excellent lecture.
Thank you. And due to the limited period of time for our meeting, I will combine two questions. One question from past president of the Azerbaijan Society of Cardiology, Professor Jahangirov, and second question from Dr. Fedotov from Russian Federation. Ovidiu, could your opinion about the impact of levosimendan on survival, and is it possible to use inotrope support for patients with terminal heart failure in outpatient setting, not inpatient but outpatient setting, please?
So Yuri, you remember very well, and I think all of you, because you started the experience with levosimendan with study, and was were negative studies. Were negative saying that in patients where levosimendan is decreasing blood pressure increasing, and levosimendan is not a universal panacea. It's really very nice drug. We are using in high-risk surgery just to avoid intra-aortic balloon pump. It's difficult to use in cardiology because we should pay a lot of attention to using systolic blood pressure. as I said, it's very useful in right ventricular causes of cardiogenic shock, but always in association with norepinephrine. And this is my opinion till now regarding prognosis of patients with levosimendan. So we like very much to see that levosimendan compared with dobutamine is decreasing natriuretic peptides. But at the end of the day, this signal was not a surrogate signal, was not very well accepted in medical community. And the second part of the question, because I don't remember.
It was related with the management of terminal heart failure in outpatient settings. Which tools, which approaches you are using in these cases?
Yuri, it's a matter of money. In very rich country, they are using Lion Heart protocol with intermittent levosimendan administration. But remember, in Europe, levosimendan is 1,000 euro. How many countries are affording to pay repeatedly 1,000 for patients with advanced heart failure? In my country, but also in Israel and any other country, and also in Western Europe, we are using dobutamine, short-term infusion of dobutamine in day care, and then we are asking patients to come again and come again and come again. But we are using this as palliative care because it's not working in terms of improving survival or milrinone. It's also very expensive. We used milrinone patients already on beta blockers, but most of the times, at least in my institution, we are using dobutamine.
So, thank you so much, dear colleagues, дорогие друзья, дорогие коллеги. Есть ли еще вопросы?
Dear colleagues, are there any more questions for our speaker? We would like to say thanks to him. Just thanks.
Thank you, all of you. Thank you, Yuri, for making this possible. Thank you so much.
Many thanks for the opportunity to have a discussion with you. That is great because that is the first chance, first time when our friends and our colleagues from different parts of the post-Soviet area are sitting together, even in online setting. Nevertheless, that is a good chance to start our communications between different countries, because we are heart failure specialists, we are cardiologists, we are doctors who are managing patients with heart failure. Many, many thanks for that. I would like to say many thanks to our colleagues who are now with us. And that is the first international meeting, and we hope to continue our educational activity together with you. Honestly to say, let to be realists, therefore you have to be in your hospital. Many of our colleagues have to be to their hospitals. Many, many thanks to you, Professor Chioncel. Many, many thanks to our colleagues, and hope to see you soon.
Thank you so much, Yuri.
Thank you, sir.
Congratulations for this type of initiative.
See you.
So, Yuri, it's a matter of friendship.
Yeah, right. Thank you.